Diseases of the optic nerve and orbit. Firstly, let's discuss the main pathologies of the optic nerve. As you know, from the neurology, the visual pathway consists of some structures. Starting from retina, consists of optic nerves here, optic chiasma, optic tracts, left and right tract, lateral geniculate bodies, this region, and optic radiations and visual cortex. Optic radiations and visual cortex. It is the brain structures. Each optic nerve starts from the optic disc and extends up to optic chiasma, where the two nerves meet. The optic nerve is about 45 or 50 millimeters in length and can be divided into 4 parts. I mean optic nerve, this part, optic nerve, can be divided into 4 parts. Intraocular part, about 1 millimeter, localized here, and we can see this part as, we can know this part as the head of the optic nerve disc. Intraorbital part, about 30 millimeters. Intracanalicular part, 6 or 9 millimeters, and intracranial part, about 10 millimeters. The optic nerve head is exist site for all retinal nerve fibers. The papillomacular bundle contains the small caliber nerve fibers, which subserve the cone system of the fovea. Optic nerve lesions have a predilection for suppression the function of this important anatomical structure and cause the following clinical signs. I'm sorry. Following clinical signs: diminished visual acuity, visual field defects, which may be of various types, diminished papillary light reactions, and impairment of color visions. Impairment of color visions. And now let's talk in details about of each pathologies. And one of the main pathology of the optic nerve, it's inflammation of the optic nerves, because according to the classification, all pathologies of the optic nerve can be divided into 2 big types. Can be divided into 2 big types. The first type, it's congenital pathologies, and the second type, it's acquired pathologies. Acquired pathologies of the optic nerve can be classified into some groups, including inflammatory and non-inflammatory pathologies. And one of the main inflammatory pathologies is optic neuritis. Optic neuritis. And now let's talk about optic neuritis. Optic neuritis, what it means? Optic neuritis is an inflammatory or demyelinating disorder of the optic nerve. On the ophthalmoscopy, it can be divided into 2 types. Retrobulbar neuritis and papillitis. What it means, retrobulbar neuritis and papillitis? Retrobulbar neuritis, it's inflammation, the part of the optic nerve disc behind the retina. And papillitis, it's inflammation the part of the optic nerve disc before the retina, the head of the optic nerve disc, which can be visible with use of some investigations such ophthalmoscopy and retinoscopy. So, optic neuritis. Let's talk about etiology. So we have problem with slides, yes?
Yes, ma'am.
Some seconds. It's okay? So optic neuritis, do you see?
No, ma'am.
It's on the first slide.
Some seconds, please. Now, it's okay?
No, ma'am.
No?
No. Сейчас да, ma'am.
Yeah, no? Okay?
Now it is okay.
So optic neuritis, yes?
Now again gone, ma'am.
So what do you see now? Papillitis? No?
The visual pathway. Second slide.
This. So what do you see?
Visual pathway. Second slide.
And this?
Or the optic nerve. Third slide.
Okay, let's do this with you this. Okay. So let's continue. Etiology of optic neuritis. Etiology of optic neuritis. So the first type of optic neuritis is idiopathic. What it means idiopathic? In large proportion of causes, the underlying cause in identifiable. The second type is multiple sclerosis. It's the commonest cause of monosymptomatic acute idiopathic optic neuritis. Thirdly, inflammatory disorders of the brain and its sheath, meningitis and encephalitis. Fourth, inflammatory disorders of the eye and orbit. The nextly, inflammatory disorders of the paranasal sinuses. 6, acute and chronic inflammations. It may be viral, bacterial in origin. And finally, in classification of etiology, depends of the etiology, it's toxic optic neuritis. Toxic optic neuritis. Then let's talk in details about papillitis. Let's talk in details about papillitis. What it means papillitis? Papillitis, it's inflammation of the optic nerve disc, the head of the optic nerve. More often this condition is unilateral. Let's discuss their main clinical features. One of the main clinical features, it's usually unilateral. It's a very important moment, unilateral. Then, presentation, sudden, progressive, and profound visual loss is the hallmark of papillitis. Then, maybe defects of visual field, impairment of color vision, dark adaptation may also be lowered. The most common field defect is a relative central or centrocecal scotoma. Central or centrocecal scotoma. Visual acuity is usually reduced markedly. Ophthalmoscopy, it's characterized by hyperemia of the disc and blurring of the margins. Disc becomes edematous, retinal veins are congested and tortuous. In some cases, there may also be hemorrhages on and around the optic disc. Slit lamp examinations may reveal inflammatory cells in the vitreous body. Look here, this is the most common field defect is a relative central or centrocecal scotoma. Look here, this is normal visual field, and this is a visual field in the pathology of the optic nerve disc. It's called centrocecal scotoma. The typical localization of this scotoma in the centrocecal region. Papillitis should be differentiated from papilledema and pseudoneuritis. The next kind of the inflammation of the optic nerve disc is retrobulbar neuritis. It's retrobulbar neuritis. What it means, retrobulbar neuritis? It is an inflammation of the optic nerve situated behind the eyeball. It is characterized by a normal optic nerve head and retinal nerve fiber layers. This is the most common type in adults and is frequently associated with demyelinization. The main clinical features, except the fundus changes, the next. Look here. Are essentially similar to that of the papillitis. They are diminished visual acuity or of different degree. So it's may be reduction of visual acuity up to 70%, 60%, or maybe reduction of visual acuity up to 10%, or maybe up to light perception or light sensation. The nextly, generalized constriction of the visual field borders, especially on red and green color, and central scotoma. Retrobulbar neuritis may be acute and chronic. Chronic retrobulbar neuritis is also known as toxic amblyopia. Recurrent attack of acute retrobulbar neuritis are followed by primary optic atrophy. And some talk about prognosis. About 75% cases get good visual recovery. Recovery takes usually from 4 up to 6 weeks. However, despite return of visual acuity, the parameters of visual function, for example, color vision, contrast sensitivity, often remain abnormal. Sometimes optic nerve atrophy may develop. The nextly, treatment and correction of this condition. One of the main steps in treatment of the pathology of the optic nerve, it's using of corticosteroids. We can use corticosteroids systemically or local. systemically with use of tap, or for example, in injection, and local with use of retrobulbar injection. Retrobulbar injection. So systemically intravenous injection, intramuscular injection, and locally it's retrobulbar injection. The next step in treatment, it's using of antibiotics of different groups. Thirdly, using of vitamin C, B1, B6, B12, for example. One of the main steps in correction of edema in papillitis, it's dehydration and disintoxication. For the dehydration and disintoxication, we can use such drugs as furosemide, inhibitor of the carbon hydrase, it's for the dehydration. For the disintoxication, we can use physician solutions, isogenic solutions, for example. And finally, the fifth, it's using of etiological treatment. Because one of the main steps of the doctor, it's to find the primary reason of this pathology. So if we see patient with the symptoms and signs of optic neuritis or papillitis or retrobulbar neuritis, firstly, you should recommend to this patient consultation of other specialists, for example, consultation of neurologist, consultation of infectionist, dermatovenerologist. Why? Because we need to exclude any pathologies of other organs, for example, multiple sclerosis, yes, and do the first step of the doctor. We can prescribe to this patient additional analysis, additional investigations, maybe CT scan of the brain, MIT, magnetic resonance tomography of the brain, and only after this, we can administer treatment for this patient. And some words about toxic neuritis. Methyl alcohol amblyopia, it's typically acute, usually resulting in optic nerve atrophy and permanent blindness. Look here, it's typical methyl alcohol amblyopia. It usually occurs due to intake of wood alcohol. Toxic agents cause edema, followed by degenerations of the ganglion cells of the retina, resulting in complete blindness due to optic atrophy. Clinical features includes its symptoms of acute poisoning and ocular features. For example, which include signs of retrobulbar neuritis with mild disc edema and markedly narrowed blood vessels, like here. So it's typical methyl alcohol amblyopia. The next thing, papilledema. I talked some minutes ago that all pathologies of the optic nerve disc can be divided into two types, inflammatory and non-inflammatory. Papilledema, it's combination because it depends on the etiology. Papilledema may be inflammatory, maybe non-inflammatory. Papilledema, it's defined as swelling of the optic nerve head secondary to raised intracranial pressure. Raised intracranial pressure may be therefore be caused by the following mechanisms. And let's call and list all these mechanisms. The first mechanism is space occupying lesions. What it means? It's intracranial hemorrhages, maybe brain tumors, benign or malignant, for example. It's maybe abscesses of brain. The secondly, blockage of the ventricular system by congenital or acquired lesions. Thirdly, obstruction or cerebrospinal fluid as the result of meningitis or cerebral trauma. Benign intracranial hypertension, for example, in pseudotumor cerebri. Fifth, silver hypertension. And finally, it's maybe hypersecretion of cerebrospinal fluid by choroid plexus tumor. But it's not common and it's very rare pathology. So, the precise pathogenesis of papilledema, it's not entirely understood, but it seems clear that intra-axonal swelling with accumulation of mitochondria and not extracellular extravasation of fluid is the principal early mechanism resulting from raised intraneural pressure. This results in swelling of prelaminar nerve axons, and early papilledema is simply the result of exoplasmic stasis at the nerve disc. The vascular changes, for example, hyperemia, venous congestion, and hemorrhages are secondary. In chronic papilledema, in addition to swollen axons, there is extracellular accumulation of fluid, edema, and ischemia. Let's talk about main symptoms and signs. Papilledema is nearly always bilateral. Patient usually gives a history of recurrent attacks of transient blurred vision. Visual acuity in majority of the patient remains normal for a long duration. It is affected only in the end stages when atrophic changes set in. Symptoms of associated raised intracranial pressure may be the next. It's maybe headache, maybe nausea, and sometimes it's maybe vomiting. So as you can see, it's the main symptom of the increasing the level of the intracranial pressure. Then functional changes, field changes. It may be enlargement of blind spot occurs in cases with fully developed papilledema. Concentric contraction of peripheral fields becomes apparent as atrophy set in. And one of the main signs we can see with use of ophthalmoscopic investigation, ophthalmoscopic picture. So, look here, ophthalmoscopic picture. Elevation of the optic nerve disc above the plane of retina. Look, this is elevation and prominention of the optic nerve disc. This becomes markedly hyperemic and blurring of the margin is present all around. Veins becomes tortuous and engorged. Look here. Soft exudates and superficial hemorrhages may be seen near the disc. So we can see little hemorrhages. Papilledema should be differentiated from pseudopapilledema in hypermetropia and papillitis. Papilledema indicates raised intracranial pressure and a neurologic emergency. The patient requires immediate admission to a hospital. Papilledema usually develops quickly, appearing within 1 or 5 days of raised intracranial pressure. Recovery from fully developed papilledema is rather slow. It takes about from 6 up to 8 weeks to subside after the intracranial pressure is normalized. Optic nerve And as a result, after papilla edema, the main complications of the papilla edema is optic atrophy. It's optic atrophy. Optic atrophy is the result of many pathologies of the optic nerve disc, and one of the main complications of chronic papilla edema. It's characterized by grayish-white discoloration and pallor of the disc due to atrophy of the neurons and associated gliosis. Visual acuity is severely impaired in these situations. It refers to generation of the optic nerve, which occurs in the result of any pathological processes that damage axons in the anterior visual system, from retinal ganglion cells to the lateral geniculate body. The major etiological types are recognized. It may be primary optic atrophy. It may be primary optic atrophy and secondary optic atrophy. How to differentiate primary and secondary optic atrophy? Primary optic atrophy, it's individual pathology without previously inflammations and previously pathologies of the optic nerve. Secondary optic atrophy, it's typical complications after previously pathologies such as papillitis, papilla edema, and other inflammations of the optic nerve disc. So let's repeat. Optic atrophy may be primary and maybe secondary, maybe primary and maybe secondary. Primary optic atrophy. Look here, what are the main signs of primary optic atrophy? The main signs can be visible on the retina with use of ophthalmoscopic investigation. And in this situation, optic nerve disc is pale, its edges or margins are sharply outlined, and retinal vessels are narrow. In secondary optic nerve atrophy, changes in color of the optic nerve disc, it looks dirty white, and its edges are not so sharply defined as in primary optic atrophy. So this is the main sign which would help differentiate the secondary optic nerve atrophy from primary optic nerve atrophy. And some words about causes of primary and secondary atrophy. There were three major etiological types are recognized. Common causes of primary optic atrophy are multiple sclerosis, intracranial tumors, pressing directly on the anterior visual pathway, traumatic severance, consecutive optic atrophy, the result of diffuse chorioretinitis, retinal pigmentary dystrophies, occlusion of central retinal artery, glaucoma, and vascular disorders may also cause optic nerve atrophy. One of the main clinical features of optic atrophy, it's loss of vision, which may be sudden or graduate onset, depending upon the causes of the optic atrophy. And it may be partial or total, depending upon degree of atrophy. Visual field loss will vary with the distribution of the fibers that have been damaged. They are central scotomas, different contractions of peripheral fields, and hemianopic defects. And ophthalmoscopic features like this: pale, edge sharply outlined, and in secondary optic nerve atrophy, dirty white, and the edge are not so sharply defined as primary optic atrophy. Treatment. The main groups of drugs which we use in treatment of the optic atrophy, it's vitamins, vasodilators, other vasoactive drugs, such as vitamins, antioxidants, drugs, and physiotherapy may be used in treatment sometimes. For example, it may be electromagnetic stimulation, infrared laser stimulation of the optic nerve disc, and other treatment. Then let's talk about orbital cellulitis. Orbital cellulitis. Look here. What does it mean, orbital cellulitis? Orbital cellulitis is the separative inflammation of the fat and cellular tissue of the orbit. The following are the main etiological types. The first type, sinus-related, is caused by extension of infection from paranasal sinuses. The secondly, from adjacent structures such as dacryal cystitis, midfacial infection, or dental infection. Thirdly, post-traumatic most commonly develops within 48 or 72 hours of an injury that penetrates the orbital septum. In some cases, the typical clinical features may be masked by associated laceration or hematoma. Fourth, post-surgical may complicate retinal detachment surgery, strabismus surgery, dacryocystostomy, and orbital surgery. And the main causative organisms of the orbital cellulitis are Streptococcus, Staphylococcus, and Haemophilus influenza. Symptoms includes rapid onset of headache, fever, pain, nausea, and in some situations it may be prostration. Some patient feels severe pain, which is increased by movements of the eye or pressure, like this. So we can see edema, redness, edema of the conjunctiva, and changing the color of this region of the skin in the region of orbital cellulitis. Eyelids are swollen, erythematous, warm, and tender to palpation. A marked chemosis of conjunctiva. The eye is proptosed actually. The most frequently proptosis is lateral and downwards. Ocular movements are restricted and painful. In advanced process, visual acuity may be diminished. Potential complications. One of the main complications is intracranial complications, which includes meningitis, brain abscess, and cavernous sinus thrombosis, and it's one of the main dangerous complications. The second, it may be supraorbital abscesses. It is relatively rare. It's in sinus-related orbital cellulitis, but may occur in most traumatic and postoperative cases. And finally, it may be ocular complications such as keratopathy, raised of intraocular pressure, occlusion of the central retinal artery or vein, and it may be optic neuritis. Treatment of orbital cellulitis. One of the main step in treatment is intensive antibacterial treatment. We can use antibiotics systemic. For example, it's parenteral and topical broad spectrum therapy with use such group antibiotics as cephalosporinum, sulfonilamides, ciprofloxacin, and other. The second step in treatment, the next group, it's analgesics and anti-inflammatory drugs. For example, anti-inflammatory drugs, it's maybe steroids, corticosteroids, and non-steroid anti-inflammatory drugs. All these drugs are helpful to control pain and fever. Osmotherapy, it's dehydration. For this aim, we can use different diuretics, or for example, 40% of glucose solution. And finally, we can administer vitamins, such as vitamins of group A, B, and C. Sometimes, if we have complications of abscesses, we should use surgical treatment. But surgical treatment, what the main step in surgical treatment? It's cleaning, we need to do in the cut, we need to clean in this region, and to implant drainage for some days. It's typical surgery. But it's very important to use special drugs, antibacterial drugs, together with surgical treatment. It's very important moment. Other types of acute orbital inflammation, it's orbital osteoperiastitis and tendonitis. Let's talk about orbital osteoperiastitis. What it's mean? Orbital osteoperiastitis is an inflammation of the periorbital region. It may involve the surrounding bones producing orbital osteoperiastitis. It may result from injuries or as an extension of infection from the surrounding structures, similar to orbital cellulitis. Clinical picture may be in two forms. Anterior orbital periostitis and posterior orbital periostitis. Anterior orbital periostitis, it involves the orbital margin and it's characterized by severe pain, tenderness, and swelling of the inflamed area. Superostal abscess, when formed, frequently busts on the skin surface. Posterior periostitis. It's characterized by deep-seated orbital pain, exophthalmos. What it means, exophthalmos is dislocation of the eye to outside, a slight limitation of ocular movements. Sometimes there may be anesthesia of the skin of eyelids and cornea. Tendonitis. Tendonitis, it is the inflammation of the tendon's capsule, usually unilateral. It is characterized by pain, increasing during eye movements, mild exophthalmos, and mild chemosis and lid edema. The main etiological factors are inflammation of the eye structures, injuries of the tendon's capsule, and postoperative tendonitis. Postoperative tendonitis. The main steps in treatment of tendonitis. The first step is intensive antibacterial treatment, so by use of antibiotics. Analgesics and anti-inflammatory drugs is the second step. If we need, we can use surgical treatment by use drainage and further therapeutical treatment. It's one of the main steps in treatment of tendonitis. Exophthalmos. Exophthalmos is defined as forward displacement of the eyeball beyond the orbital margin. It may be unilateral and bilateral. Causes of bilateral. exophthalmos are developmental anomalies of the skull, for example, Tauber skull, craniofacial dysostosis. Secondly, inflammatory conditions, for example, Mikulicz syndrome and late stage of cavernous sinus thrombosis. Thirdly, endocrinal exophthalmos, thyrotoxic or thyrotropic. Fourth reason, tumor. And finally, it's maybe systemic disease. For example, amyloidosis, Wegener's granulomatosis. Some other situation, another situation in unilateral proptosis or exophthalmos. The first reason of unilateral exophthalmos is congenital conditions. It's maybe dermoid cyst, orbital teratoma. It may be traumatic lesions, for example, orbital hemorrhage, foreign bodies. Nextly, it may be inflammatory lesions, orbital cellulitis, abscesses, thrombophlebitis, cavernous sinus thrombosis. Sometimes it may be cyst of orbit, and in some situation we can find the primary reason, such as tumors of the orbit, primary, secondary, or metastatic. It may be benign or malignant tumors. Benign or malignant tumors. So, orbital tumors. Let's talk about this. Orbital tumors are not very common, but unfortunately, sometimes we can see patients with these pathologies. Orbital tumors include primary, secondary, and metastatic tumors. Classifications includes vascular tumors, tumors of the lacrimal gland, cystic lesions, neural tumors, and several others. The main signs of orbital tumors are progressive exophthalmos. It's dislocation of the eye globe to outside, and progressive, it's very important moment. The degree of exophthalmos depends on the localization and size of the tumors. There is mild to severe restriction of the ocular movements. Frequently it is associated with visual acuity loss, diplopia, and central scotoma. Ophthalmoscopy may reveal papilla edema, optic nerve atrophy, hemorrhage. Sometimes it may be retinal detachment. In late stage, there may be increase in intraocular pressure, corneal ulceration. For example, look here. Another sign of orbital tumors, absence of decreasing of the eyeball reposition during their palpation. Palpation should be carried out to know compressibility of the tumors. Röntgen investigation, it's one of the most important tests in case of orbital tumors. In some cases, very useful to use orbital venography, carotid angiography, radioisotope studies. CT scan, ultrasonography, and magnetic resonance imaging also help to put correct diagnosis. One of the main question, one of the main problems in ophthalmology, it's investigation, diagnostic, and treatment of tumors. And it's very important to determine type of orbital tumors, benign or malignant. Speed of tumors growth can help. Benign tumors grow slowly, that malignant. Look here, benign tumors. The main benign tumors of the orbit are dermoid cyst, hemangioma, and osteoma. Capillary hemangioma is the most common tumor of the orbit and periorbital areas of the childhood. It appears as periorbital swelling in the anterior part of the orbit. It tends to increase in size on straining or crying. Hemangiomatous tissue may be seen in the fornices on awaiting the lids. Cavernous hemangioma is the commonest benign orbital tumor among adults. The tumors are usually located in the retrobulbar muscle cone. Dermoids are the common development tumors which arise from an embryonic displacement of the epidermis to a subcutaneous location. Appears as a firm, round, localized lesion in the upper temporal or upper nasal aspect for the orbit. Displacement of globe is not seen as these are located anterior to the orbital septum. This tumors doesn't extend deep into the orbit and are not associated with bony defects. Treatment. One of the main steps in treatment of benign tumors is usually surgical. Surgical excision, one of the tumors, it's undertaken via orbitotomy approach. Since the tumor is well encapsulated, complete removal is generally possible. Malignant tumors includes sarcoma and carcinoma. Rhabdomyosarcoma, it's one of the main dangers of the tumor. It is the highly malignant tumor of the orbit arising from the extraocular muscles. It is the most common primary orbital tumor among the children, usually occurring below age of 15 years. Sometimes the clinical presentation mimics an inflammatory processes. It may invade any part of the orbit. Carcinoma. Carcinoma is an unusually metastatic orbital tumor involving the orbit by hematogenous spread from a distant primary focus, lungs, breast, prostate, thyroid, and rectum. In some cases, from skin of eyelids, conjunctiva, and lacrimal duct. Treatment of malignant tumors. The firstly, it's high dose radiation therapy combined with systemic. The second step is chemotherapy, and the third step is surgical treatment. But one of the main tasks of the doctor in situation, if we have a malignant tumor, we need to recommend to this patient consultation of oncologist, and we need to recommend examination and inspection of other organs. For example, you need to recommend X-ray examination of the lungs, investigation of the brain, investigation of the gastrointestinal tract for the excluding or including of metastasis on these organs. And only after this, we can recommend to come to the oncologist and to get the treatment. And final question, this is syndrome of superior orbital fissure. Superior orbital fissure. The superior orbital fissure lies between the lesser and greater wings of the sphenoid. A lot of vessels and nerves pass through the superior orbital fissure. Superior ophthalmic plane, oculomotor, abducent and trochlear nerves, ophthalmic nerve. When the orbital apex in case of orbital tumor, retrobulbar hemorrhages, foreign bodies is implicated. In addition, the typical picture of orbital apex syndrome is produced. It includes mild or moderate exophthalmos, ptosis, partial or full, total ophthalmoplegia, mydriasis, paralysis of accommodation, anesthesia in the region of supply of ophthalmic division or fifth nerve. And one of the main step in treatment depends on the cause of this syndrome. For example, If we know that the main reason, of course, it's neurological problem, it's treatment for the to the neurologist. If the main problem it's trauma, so a treatment to the neurosurgeon or traumatologist, for example. So, dear students, thank you for your attention. So it's final lecture today or no? Please tell me.
Yes, madam.
So okay, please some seconds. I need to know to look who's present. Okay, dear students, thank you for your attention. With some students, we will see the classes. Please, good luck.
Thank you, madam.
Thank you, madam.
До свидания.
Thank you, madam.
До свидания.